All right, so this is a modalities quick review for the boards. I am going to focus more so on the bigger ones that you see for the boards, which is ESTIM, ultrasound, and maybe a little bit of traction. Just keep in mind that I may not jump a lot into things like diathermy or laser or aquatics. It doesn't mean that it's not in the board, but it is more likely that in your chunk of modality-based questions, they're gonna go for the ones that are used more clinically, which a big one is ESTIM, and ultrasound is like the second in command. So I'm gonna focus more on those. Doesn't mean that those other ones won't be in there, but maybe one or two questions. I think it'll value you more if you focus a lot on ESTIM and ultrasound. Not only because you'll see more of those, but also because they have more content to focus on that can be asked about. So the first part of the review is just don't forget your principles of heat transfer. Most modalities transfer heat in some kind of way. And so those other modalities that we're not going to talk about as much, like your fluidotherapy or like your diathermy or your UV lamp or something, maybe you won't get asked too many things about parameters and such things, but you may be asked a question of this sort where they ask you, how is the energy transferred? Is it conduction, is it convection, and so forth and so on? And what are the examples of that? So just to remind you, conduction is contact transfer of heat, two different items that are different temperatures touching each other and then transferring the heat by direct contact. So anything that is already hot or already cold that goes directly on the body, that's probably going to be conduction. The hot packs, cold packs, paraffin, ice massage, cryo cuff, you have a cold device or a hot device that goes exactly on the body. With paraffin, it's hot wax, but it's still direct contact with the hot wax. So that is conduction, okay? Your superficial heating and cooling, basically. Convection, there has to be some type of medium, as we call it, a particle, a liquid, or air, but that medium has to be moving. So what makes the difference between getting in a hot pool where you're making direct contact with the hot pool is that the pool, unless it's a wave pool, usually doesn't have movement. So if I just step into a hot bath or a hot pool without it being a wave pool, it's just a regular pool that doesn't move, that would be conduction. But if that pool is actually a whirlpool and the water is moving and agitated, that makes it more convection. So there has to be that agitation aspect. So medium, air, water particles, agitation and movement that is creating faster movement of molecules that will increase the heat transfer, that is going to be convection. Can these things have a little bit of both conduction and convection? If you do have, let's say, a air moving, but it's hot air, yes, you do have that just different temperature thing that is making you hot, but the movement of it, the agitation of it, will cause even faster transfer of energy, okay? So your examples are fluidotherapy and whirlpool. Conversion, the key word or the key thing that I look at is that it converts. So something that was not heat, something that you look at and you know it's not hot air, it's not hot liquid, it's not a hot pack, it's not a cold pack, you know it's not a hot or cold thing typically. But for some reason, it's creating heat, like a sound wave. When you think of a sound wave, it's floating in the air, you don't see a sound wave and you don't hear sound and be like, it feels hot in my ear, right? So it is not a typical heating or cooling thing, but somehow when you get enough of them together, and again, things happen with molecules and atoms and all that, it changes or converts into heat, okay? And really the main examples of those, if you just kind of stick with these two, you're good, is diathermy and ultrasound. Those are the ones that work through conversion, okay? Radiation, just think of light. Think of light and you'll be fine. If you see a light bulb or a source of light popping out, the only thing is that there is light that we can't see, so you know, I say if you see, but you may not see it, right? But typically, if you think of something that has some type of bulb and it's a light source, it's probably radiation, including the sun, right? Infrared lamp, UV lamp, laser, and so forth. And then evaporation, we really, physical therapy wise, we really don't use that much. Maybe evapocoolant spray is the only example that I know of, but it's not as common as the other ones. And that happens when the liquid changes to vapor, and so that's why it's called evapor or vaporation, right? But as long as you know that one, you should be fine. So besides electrical stimulation and ultrasound, the other commonly asked modality that you'll see, just because it's so easy to use as kind of a secondary thing, and so commonly used that you could educate your patients about, is just your basic superficial hot and cold things like your ice and your hot pack and cold pack. So I did throw in here thermo and cryotherapy review and knowing the different effects of hot and cold. I put an arrow up for hot and a arrow down for cold because most, not everything, but most things, the heat increases it and the cold decreases it. So that's the way I keep it compartmentalized in my mind, of kind of knowing most of the differences. Maybe not all, but most. So if you look at hot, it increases blood flow. If you look at cold, it decreases blood flow, right? If you look at hot, it increases vasodilation. If you look at cold, it decreases vasodilation, or it leads to vasoconstriction, which is basically the opposite of vasodilation, which goes back to the blood flow, right? If you look at hot, it increases nerve conduction. If you look at cold, it decreases nerve conduction. So it's hard to remember. Hot mostly makes things happen a little bit more, and cold kind of limits some things from happening. But there are times where it's not quite the opposite, like with the pain threshold. Both increase the pain threshold, which basically means that the patient can tolerate more pain, which means they feel less pain. And both of them do that the same way. There's no opposites there. Hot doesn't really affect tone as much. It does affect the collagen extensibility in the muscles and tissues, but not the tone itself, because tone, muscle tone, is a nerve thing. And the one that affects the nerves the most, I wouldn't say only, but the most, is cold. Cold has a good impact on nerve conduction, and kind of not letting nerves overwork a little bit. So that's what's going to affect tone the most. And then hot decreases stiffness and cold increases stiffness. So there's another instant where it's flipped, it's the opposite. So that rule about hot increasing and cold decreasing works for most things, but as you can see, there are some that are not like that. So make sure you know those exceptions to the rule. As I've always said, one thing you do have to know about mostly everything, if you don't have time to look at everything in a subject, at least know when to not do it. And so these are just the contraindications and contraindications, maybe some precautions of hot and cold. Definitely know those. Again, if you know what heat does and you know what cold does, the contraindications make sense. It makes sense that if heat increases blood flow, if heat increases inflammation, if heat increases metabolism, Anytime you don't want increased blood flow and you don't want increased cell metabolism, you're probably going to avoid it. So you're going to avoid it when you already have a lot of blood flow, like when you have bleeding issues or inflammation. You're going to avoid it when you don't want the cells to work too much, like malignancy, because cancer cells, if they start working a lot and they have more metabolism, they're going to overtake everything. So you avoid it with cancers. So there's certain things. And so cancer, I would say, is a big one to know, because with heat, it's a contraindication. But with cold, cold is I'm not going to say it's the only, but it's one of the main ones that you could actually use a modality with cancer. Most other modalities are contraindicated with malignancy, or they're at least precautious with malignancy. Cold, malignancy has no effect on cold, and cold has no effect on malignancy. It is probably one of the only ones that is safe to use with your cancer patients if they like it and if they can tolerate, and of course if they don't have any of these other contraindications. Again, DVT, it's a blood flow issue, so if this increases blood flow, you don't want to make it worse. Infection usually leads to fever and increased temperature already, so we know the rule. If it's hot already, don't make it more hot. If, again, things are going on already, don't make them worse so that they continue. You're trying to kind of stop it. And then cryo, if anybody has a reaction to cold in a negative way, which they list those specific fancy names, urticaria, Raynaud's, cryoglobulinemia, basically all weird reactions to cold, that's a no, right? So if you ever see a case in your boards where it says, patient, you put on a cold pack and then they started turning blue and red and then they started having severe pain, the answer is stop using it. Like, it's that simple. Whether you know the name of the condition or not, which I hope you do by now know what these are, but if you don't, at least if you had to pick what to do next or what to, should you use it, the answer is no. Or if your patient told you they have these reactions, you shouldn't be using it, right? But as I said earlier, cold is the one that affects the nerves the most. So if your patient had a recent nerve surgery or something nerve related, sometimes we back off, at least in the beginning especially, while those nerves are regenerating. And then if they're already having a hard time getting blood flow somewhere and this decreases blood flow, then you probably shouldn't use cold to continue to decrease blood flow. Both have infection, because infection, really, you can avoid it no matter what, right? You shouldn't be doing too many things with infection until we find out the source of the infection and treat that first. Okay, other details about hot and cold use, particular, again, talking about superficial hot and cold. Most of the time we use these things for 15 to 20, 10 to 20 minutes, sometimes up to 30, but no more than that, unless you're using cold for a specific function, such as spasticity. And then there's also an exception with ice massage where you use it less than the 10, 15, 20 minutes, only 5 to 10 being your max, because it's direct ice to the skin. Approximately temperatures for your cold stuff is around 50 to 60 degrees. Approximately temperature for your hot stuff is over 100 degrees. Again, I'm not giving you specifics. I'm giving you generalizations so you can be able to pick them out in your boards if you have options A, B, C, D. If you think about what our body temperature is, about 96 to 98 Fahrenheit, then you're probably not gonna go too much lower than that, which is why you go around 50, 60. Think about when especially us that we live here in Florida, right? When we have to feel 50, 60 degrees, it's pretty cold, right? So you don't want to go too much colder than that. And then when it comes to hot, it has to be hotter than our body temperature. So it has to be over 100, because our body temperature is already about 100, right? So it makes no sense that if my, as a person, my temperature is 98 degrees, and then I put on a hot pack that's 99 degrees, it's probably not going to heat me up that much because I'm already that hot, right? So you need to put it hotter. So it's usually 120, 130, something like that, okay? But of course, you don't want to go too extreme. Don't forget your C-band, and what that means, that it is normal, but that of course, if it's too uncomfortable, your patient just may not be a good candidate for that. And don't forget your layers for things like hot pack and paraffin, particularly the dip and wrap method, because that could be a point of contention that they ask in the boards. All right, ultrasounds. One of your deep heating agents, the other one is diathermy, but again, diathermy is not even asked about that much in the boards. Remember that the boards wants to test you. Yes, anything is game, but they want to test you on what is going to be real to practical things you're going to do in the field, right? They don't want to go around testing therapists on things that are very specialized and nobody's going to really know about, and then you get a really smart therapist that passes, but nobody else can treat patients because they didn't know about this crazy new thing, right? So they want to keep things practical to what you're actually going to see out there and feel out there. And again, diathermy is not as common. But anyways, diathermy and ultrasound are really your main two deep heating agents, which means it can go past 3 centimeters of tissue. But it can be a heating agent if you are talking about thermal ultrasound. The other use of ultrasound is non-thermal, and that would be for in the inflammatory phase, healing anything that just happened, anything that needs kind of that push through to make sure that we get to the next stage of healing. So pain, inflammation, chronic wounds, things like that, to try to make sure that we get them better, basically past the spot where they're at. Your non-thermal effects are happening due to cavitation, which is just that agitation of molecules that the sound waves cause inside the body. And again, it is a mechanical form of a mechanical modality in that the sound waves create vibrations. Mechanical is going to be anything that pushes, pulls, vibrates, agitates, moves. So it is mechanical because of the vibrations, but those vibrations, if you do them at a frequency fast enough, can cause molecules to collide and then create heat, but they have to convert to heat or change to heat by having a certain frequency. And that's why there's thermal and non-thermal. So you can use ultrasound without it heating. You just have to use the right numbers, right? And then you can use it for heating if you use the right numbers. That's when it converts, when it is used for heating purposes. Sound waves at this frequency do not travel through air. So there has to be a coupling agent, a water or a gel that we typically use, because our voice travels through air, but we have a different frequency when we speak and when we hear music and stuff than the type that we use for therapeutic ultrasound. If not, it's going to bounce off the air and go back into the crystal, right? If we don't use a gel, and then it's not going to go into the body, and the point is it's supposed to go into the body. So we have to make sure we put a medium or a coupling agent for it to go through. A lot of times it's gel. The only other use is phonophoresis, which is basically delivering medicine through the skin using ultrasound transdermally, but again, that is not as commonly used as the other purposes. Of course, you have to know your contraindications. Because it can be a heating agent, you are going to go back to your heating contraindications if you are using heating. like your DVT, like your infection, like your malignancy. That doesn't change. Just know your heating ones and then throw them in here, okay? But that's only if you're using your thermal settings. The ones that are different or specific to non-thermal, maybe things like the epiphyseal plates in children, to not do it over the carotid sinus or reproductive organs, over pregnant uteruses, over pacemakers. Those are a little bit different than your superficial heating and specific to any type of ultrasound. And avoid over bones, except if you're using a very specific type of ultrasound that is for fracture healing, and it's very, very, very low intensity. I mean, it's very rare, again, that your board will ask you for such a specific number, but if they do, make sure you pick the lowest intensity one that you could pick if they're asking about fractures and ultrasound, because it can be used in certain instances for fractures in ultrasound, but it has to be non-thermal and very low intensity. So make sure you understand what that means. All right, so here are our parameters. Know what the effect is of each parameter. Frequency affects depth, how far or deep it goes. Remember, it can be a deep agent, a deep modality. So if we say that anything is deep, it means it goes past 3 centimeters of tissue. 1 to 3 is superficial, 3 to 5 is deep. Okay. Duty cycle is the main thing that is going to affect if it's thermal or non-thermal. 100% for thermal, 20% for non-thermal. We also call non-thermal pulsed, and we also call thermal continuous. Intensity has to do with just the power of the waves. It's related to if you want these heating things or not. If you want it to go deeper and hotter, you probably want a little bit more power. If you don't want all that, you want a little bit less power, okay? And then your treatment time, remember that ultrasound is only used for 5 to 10 minutes. It is not a 20-30 minute thing unless you're doing like a whole bunch of little sections back to back, but that's rare, and that's kind of not efficient in a physical therapy setting. So it is a short time frame that you do this, but it does require the therapist to be there with the patient the whole time and be busy with them, so they can't see dual patients or really work with anybody else, right? So unfortunately, my camera placement covers some things that you can't see, but I'll tell you what it says in there. But this is going into ESTIM. Because ESTIM has so much information, again, these presentations are not meant for me to give you the 3-week lesson on ESTIM. It's just meant to summarize some things that are important that you want to make sure you focus on or you look at, and then in your own time you go back and use your books and really look at the details, if you will. But the first thing I did here is just go over the different types of ESTIM, what you mainly use it for, what waveforms you might use, and then like some of those other names or things that may be associated with that. And then other little key points that you gotta know, right? So the first thing is, if you see TENS, they're not talking about the little box machine. Although a TENS unit usually is used for TENS, know that TENS is actually a type of ESTIM, which is transcutaneous electrical nerve stimulation, and that's for pain, okay? So you're gonna use either a pulsed or alternating waveform. Those are both biphasic, meaning they go from negative to positive, cancel each other out. They don't leave any ionic charge or anything. And other names or other things you may see associated for pain modulation will be pre-mod, IFC. Usually it's continuous. I mean, there is like the acupuncture effect that may not be as continuous, but it's usually continuous. It's usually very high or very low frequencies, and there shouldn't be what we call a tetanic contraction. So with your low rate ESTIM, your low rate TENS, there is a little twitch, but it doesn't create as much twitches together that it makes the muscle work. And that's what we mean by a tetanic contraction, okay? Whereas the next one, NMES, which is neuromuscular electrical stimulation, does create a tetanic contraction. That's actually the point, right? So it is to create a contraction, okay? And so that's what the use is for innervated muscle to contract, usually because your patient is having a hard time even acknowledging that the muscle is there and getting it to work, or because they're not strong and you're not getting a strong enough contraction and you're trying to make a stronger contraction. So it is for strengthening, it is for muscle re-education, and then it also is used for decreasing muscle spasms and the muscle pump for edema, but only if the edema is due to lack of motion, not if it's due to like inflammation or lymphedema or other reasons like that. You also use pulse or alternating waveforms in biphasic for this, just at different frequencies and pulse widths, okay? You may also hear the term Russian related to your NMES. And what makes this one a little bit different is that it has on and off times and ramp times, whereas your TENS pain stuff does not. It's just continuous. It just keeps going. Your on and off time, remember, should be related to patient fatigue and patient exercise. So think about if you were exercising a patient and you wanted them to do, you know, certain contractions, you wouldn't want it to be for them to be contracting and using the muscle for 20 minutes straight. You would give them rest, right? And then when they're beginning, they need more rest, and when they're further along in their training, they could probably use less rest, and so you use it that way the same. EMS is electrical muscle stimulation. It's for direct stimulation to a muscle that does not have a connection to the nerve, a denervated muscle. It's a very strong, almost shocking muscle contraction that uses direct current, which is monophasic, not biphasic, because you don't want to cancel the charges out. You want the charges to be there so that it shocks the muscle. However, this is not even as commonly used, to the point that you don't gotta know too much about it except that. Okay. ESTR is electrical stimulation for tissue repair, aka healing, and here we're talking about a patient in the inflammatory phase which has inflammation, or for wound healing purposes. This uses a pulsed waveform, but it's monophasic this time because you do want an ionic charge, and the main type of ESTIM, if you will, that you use is high volt pulsed current, which is also known as HVPC. What it says there on the side that I'm blocking is that you do have to consider a polarity now, and if it's for inflammation, the polarity is negative. Okay. Iontophoresis is the delivery of medications using ESTIM this time, usually again for pain relief or decreasing inflammation. It uses a direct current that is monophasic as well. And on the side there that I'm covering, it also talks about polarity and medications. You do also have to consider a polarity. It should be the same as the medication. So if your medication has a negative polarity, your pushing electrode should have the same polarity, and a negative one. And the most common one used is negative because we use dexamethasone a lot, and that's usually for inflammation, and that usually has a negative polarity. It's a anti-inflammatory type of medicine, right? A corticosteroid. And then this Ionto has a totally different set of parameters. So I think in the next page I'm going to go through parameters. For Ionto, it's completely different. If you remember, it's not frequency and pulse width and all that. It's just 40 min MA, right? So whatever equals to 40 min MA, you know that you're good. So again, here is your parameter review. Again, set up in tables. For pain or for TENS, it's either very high or very low in your frequency. And again, frequency is hertz or PPS, pulses per second. Your pulse width or your pulse duration correlates with the frequency. So if you know your frequency is high, then your pulse width is probably going to be a little bit lower middle. And if your pulse width is very low, then your if your frequency is very low, then your pulse duration is probably going to be higher in the hundreds, okay? So once you kind of got one down, you should know that it correlates to the other one in almost the opposite way. And that is true for the next one, which is ESTIM as well. But because ESTIM, NMES, muscle contraction. But because for NMES, we always use kind of the same range, which is 35 to 50. Some will say 35 to 80, depending on what you're looking at. Your pulse width is pretty much always in the hundreds. It's always high, okay? Again, know that for pain, you don't really have an on-off time. It's continuous. You don't really have a ramp time. And your total treatment time when you're using high rate frequency is as long as tolerated, but when you're using low rate frequency, it does have a limit because it does cause, even though it doesn't cause a strong muscle contraction, that twitching can get fatiguing as well. Same as your muscle contraction, 30-minute max is where you're going to go. Okay, for your wound healing and your edema, it stays around the hundreds in both frequency and pulse duration. Treatment times are a little bit longer for wound healing, and you do have to take into consideration polarity. All right, so once again, I didn't cover things like traction, and I didn't cover things like aquatics and all of that. I stuck with your hot, cold, ultrasound, and ESTIM because those are the bigger ones of modalities. But if you do have any questions on any of that stuff, please feel free to comment, contact, etc., so I can do something separate for that. I just want to give you the more important board-based content and make sure we cover that. So the rest, I believe, is just questions. So let's start with this first question, which is, a patient is treated using pulsed wave ultrasound at 1.2 watts per centimeter square for 7 minutes. The parameters of the pulsed wave are 2 milliseconds on and 8 milliseconds off. What duty cycle should the PTA document? Okay, so I'll give you a second. So remember, duty cycle is written in terms of percentages. And even though there are other options besides 20 and 100, we almost always use 20 and 100, 20% and 100%. But these options that are here do exist in some machines. But really what it's asking you, the reason why it's written as a percentage is because if it's on the whole time, it's on 100% of the time. If it's on 50%, it's on half of the time. If it's on 20%, it's on 20% of the time. So if the machine is going on for 2 seconds and off for 8 seconds, on for 2 seconds, off for 8 seconds, the whole time back and forth, that means that it's on only 20% of the time, because out of a total 10 seconds, you only have it on 2 seconds at a time. So that's 20% of 10, right? So your duty cycle would be B, which is 20%. A PTA performs ice massage on a patient with infrapatellar tendonitis. The most appropriate treatment time is typically how long? So this is an easy question. It's really asking you how long do you use ice massage, and we talked about that parameter. So I'm going to jump right into it. The answer is B, because ice massage is done for 5 to 10 minutes. It's not done past 10 minutes, so C and D would be canceled out, and it's too short to do it for 3 to 5. So the answer is B. Now this says a PTA prepares to use phaneophoresis, which again is the delivery of medication transdermally using ultrasound, as a component of the plan of care. But they're concerned about the potential of the intervention to exacerbate the patient's inflammation. Which of the following actions would be the most effective to address this concern? So this is a really good applicative critical thinking question that is not something we typically cover, but it's something that we have given you enough information for you to think critically and try to figure out what's going on here. What are they asking? Okay, so they're saying, first of all, it's clear that they're using phaneophoresis. The thing about phaneophoresis is that the parameters don't change. It's not like Ionto, where it just has a totally new set of parameters. Phaneophoresis, you use the same frequencies and the same duty cycle and all that. You choose basically which one you want to use, and then you just do the ultrasound with the medication. So parameters wise, it is not a whole weird number. You do got to think of those parameters. However, the key word that they're mentioning to me here is inflammation, right? I got to look at these options and I got to think which one is going to affect the inflammation the most to not do that, or which one is best for inflammation to do that. Okay, so let's look at it. A and B. A says utilize ultrasound with a frequency of 1 megahertz. Well, 1 megahertz affects the deaf. We don't have any information about what they're trying to reach, and that has nothing to do with inflammation. If I go deeper or not as deep, that's about what structure I'm trying to reach. It has nothing to do with the inflammation, okay? I can go deep with a 1 megahertz, and I could put very low intensity and very low duty cycle and still use it with inflammation. So that really has no effect. So I would take that out because it has no effect on my concerns. It doesn't make a difference, okay? Limit treatment time to 5 minutes. Again, I mean, maybe very indirectly you could say, well, if you're using it less time, it won't mess it up that much. But to be honest, and if you've ever had an ultrasound burn, and I hope you haven't, but to be honest, if you have, you feel the burn 1 to 2 minutes later. So if you have it high enough and you use it for 2 minutes, you're still gonna burn the patient and you're still gonna cause more inflammation, even in 2 minutes. So I would say limiting it to 5 minutes won't be the best option because of that, okay? Then you have C and D. Incorporate a 20% duty cycle, says C, and select ultrasound intensity less than 1.5 watts per centimeter square, okay? Well, the one that makes the most different is the one that is going to make it not contraindicated with inflammation. So to me, I'm looking for non-thermal because I know thermal is contraindicated for inflammation, right? And we don't want to mess up their inflammation. So I probably am gonna pick C because that's the one that has the most effect. D is good too, But again, if you're using 100% duty cycle and using a 1.0 watts, that's still pretty hot, okay? So C is going to be the one that makes the most difference. And if you do look back in your modalities book and look at the parameters they say to use for phono, it is usually 20% duty cycle with a very low intensity from 0.5 to 1 watts per centimeter square, which already indicates what you're doing there. So the closest one to it would be C. D is not bad, it's just not the best. You would use an intensity that's not that high, but that's not what's going to make the greatest difference. Because again, if you have a high duty cycle, then your 1.0 intensity is still going to potentially burn them. C is a much better option. An athlete presents with 5 out of 10 pain, muscle spasm on the left upper traps as a result of a strain that occurred 2 weeks ago. The plan of care indicates the use, I think it's supposed to be use. Yeah, the use of a combo of both ultrasound and ESTIM. So combination ultrasound and ESTIM. So they give you in these options something with ultrasound and something with ESTIM, and you got to make sure that you pick the best for both, right? What best represents the appropriate parameters? Okay, so I would start with one and then go to the other. I would look at all my options of ultrasound and be like, what works with this patient? And then eliminate the other two, because you see you have continuous, continuous, pulse, pulse. So I would try to eliminate either these two in the top, A and B, or C and D, depending on the ultrasound. And then when I limit it to 2, then I will look at the ESTIM part and see out of those 2 which is best, right? So you're talking about an ESTIM. It's not acute because it happened 2 weeks ago, but it's not super chronic, right? However, because it's not acute and because you're thinking ultrasound for a muscle spasm, your non-thermal effects are going to do nothing for a muscle spasm. And again, it's not contraindicated because it's not acute. It's 2 weeks ago. So I definitely want to go with continuous ultrasound for that heating effect because I can use heat. I may be cautious with it. I may not go as high or whatever, but I can use heat and should use heat. There's nothing that tells me I should not use heat, considering that it was 2 weeks ago, okay? And again, non-thermal ultrasound will have no effect on a muscle spasm. It won't do anything to the muscle spasm. So that leaves me with A and B, right? I canceled out the pulsed one in C and D because of the ultrasound by itself. But now I have to look at A and B and see what is the best option for ESTIM, because we're using a combo, right? So A says intense motor level ESTIM, and B says comfortable sensory level ESTIM, okay? Motor we know is a contraction of the muscle, and sensory is probably more pain related, right? It's a little bit tougher one because you can use motor level ESTIM for muscle spasms. If you look at NMES, it can be used for muscle spasms. However, the word that I don't like here is intense. Because we just said, yes, it's not acute, but it's not that old, right? It still happened 2 weeks ago. On top of that, it happened because of a strain. So it happened because the muscle was overworking, right? And then you're going to go and make it like intensely work again? Probably not. I would just stick with pain for now, considering the time frame. And we're already getting enough heating with the ultrasound to try to help reduce that muscle spasm. So until more time happens and until that muscle spasm calms down, I wouldn't go as intense with the contraction part. So my option and the correct option would be B, because you get the heating for the muscle spasm, which is indicated with ultrasound, but you don't get as intense of a contraction, considering that the issue happened only 2 weeks ago and that it was because of a muscle contraction issue. And that A has the word intense in it, which tells me to back off a little bit. A patient was instructed to apply high rate TENS to the low back to modulate a chronic pain condition. The patient states that the TENS unit is no longer effective in reducing the pain in spite of increasing the intensity to the max. So you know when you tell a patient to go home and use their TENS unit at home, you tell them, if you don't feel it anymore, crank it up. So they've already been doing that. They've been cranking it up, they've been changing that, and they still feel like it's not really doing anything, right? How should the settings be altered secondary to the patient's subjective complaints? Okay, and again, what are their subjective complaints? They're pretty much saying it's not really working to change my pain. The reason why they're using the TENS is for pain, chronic pain, and it's not, they don't feel like it's doing much, right? Because they already cranked up all the intensity and all that, okay? So what should you do? Should you switch to low rate? Should you increase the frequency? Should you switch to modulation? Or should you decrease the pulse duration? Okay. I'll give you a tidbit here. B, C, and D. B, C, and D are all saying the same thing. Okay. If you remember what modulation means, it means to change a parameter to see if the patient can feel it again, right? So increasing the frequency, decreasing the pulse duration, that is modulating, okay? And then C says modulate. So they're all modulating. If you have three similar options then that are practically saying the same thing, it's probably not the right answer because there's no way to differentiate what the difference is going to be. Plus, this patient has already been modulating. Increasing the intensity is also increasing a modality. Is also increasing a parameter to modulate. So the patient has been modulating. C says modulating. B says modulating. D says modulating. They all say modulating, something the patient has already been doing and it hasn't been working. It's too similar for comfort for me. So the right answer is A, which is okay to choose because low rate TENS is also for pain. Low rate TENS is better for chronic pain, which the patient has, and you already tried the other options of changing parameters to see if that helps, and your patient didn't really care for it. They didn't like it. So let's try the other pain treatment, which is A, and see if that helps, as long as it's not contraindicated, and it's not because there's nothing in the question that tells you it's contraindicated. They do specify it's for chronic pain, so the answer would be A. All right, so this is a fancy one that may need a little bit more explanation from me, but there are aspects within the options that you should know as a student, okay? So the question says, a patient presents in inpatient therapy with right lower extremity edema post-surgery. Which of the following parameters are the most appropriate for this patient's impairment, okay? So what impairment are they talking about is obviously edema. Post-surgery, that tells me again it's acute, like it's something that recently happened. If they're an inpatient and they just had surgery, this is acute edema. This is not chronic edema. This is not just because they've been sitting there. They just had a traumatic surgery and you have edema because of that, okay? So that should indicate to me I need something for acute edema. I need to think of my ESTIM options. What is for acute edema out of these options, okay? So they give you the phase, monophasic, polyphasic. They give you the type of current. They all say pulse current, so that's a given. They give you a frequency, and then they give you a cathode with a polarity, okay? Now, two things stand out at me when I look at these options, right? What am I using for acute edema? And why are they giving me cathode and anode? There's really only two types of ESTIM that you consider cathode and anode. If you are doing TENS ESTIM or NMES, you don't care about cathodes and anodes, okay? We don't care if it's negative or positive. We don't care about polarity. We don't care about black or red, not with TENS and stuff. So I know that I'm not using TENS type of ESTIM. I know that I'm not using EMS type of ESTIM. I know that I'm not using NMES type of ESTIM. I have to be using one of the, if you look back at my chart that I showed you earlier, one of my two bottom ones that said polarity, right? But it's not talking about medication, so it's definitely not, what do you call it? Not ionto, right? Which is one of the polarity. There's only one type of ESTIM that we talked about that you care about polarity, and that is ESTR, which is using HVPC for acute edema, right? So ESTR or HVPC is monophasic if you look back at that chart that I told you, okay? We want an ionic charge to help with galvanotaxis, which is the pushing of, the calling of the right molecules, if you will, to, well, the right cells to help with the inflammation, okay? So that helps me eliminate A and C, because if I know that ESTR or HVPC is monophasic, I can eliminate A and C, which talk about polyphasic. And whether or not you know what polyphasic is, doesn't matter. You should know that HVPC is monophasic. Doesn't matter if you know what polyphasic is, okay? So that leaves me with B and D, okay? B and D, B says, they both say monophasic pulse current. We know HVPC is a pulse current, so great. It's a monophasic pulse current, great. Gives me frequency of 240 pps in B and 120 pps in D. Depends if you know this parameter. I know it's 120, so I already know it's D, right? But if you don't know, if you're not sure, oh, I don't remember that number, was it 140, was it 240, then go to the next part, anode or cathode, okay? I already know it's D, but if I read further in D, cathode at site of inflammation, cathode is your negative, okay? Cathode is your black thing that gives you the negative polarity, and we said many times negative is for inflammation, negative is for inflammation. So there's three things there that indicate this bottom one is right. It's monophasic pulse current, it's 120 pps, which is the correct parameter, and there's a negative polarity cathode at inflammation. That makes it completely right. That makes it D. When it comes to cathode and anode, you may not know. It doesn't say negative or positive, so you may be like, how the heck do I know that? The way I remember it is the word cathode has a plus, which you would think it's for positive, but I just flip it. I just go, it has a T, so it should be positive, but it's the opposite. It's negative. And that's how I remember it. Might not work for you, but it helps me because I know it's the opposite of what I would think it would be. So that's how I remember. But cathode is usually negative, at least with ESTIM. I'm not talking about batteries and stuff. I'm talking about ESTIM. Cathode is negative and anode is positive. So we know we want the negative. So this question says, which of the following is the primary modality to relieve pain at a fracture site? I talked about it earlier. Excuse me. I said that ultrasound can be used for fractures, right? Now let's see what options they have. Thermal ultrasound, that's the only ultrasound option they have. Is it thermal though? No. So it's trying to trick you to pick ultrasound because you're like, oh, I heard Ms. Nieto say that you can use ultrasound for fractures, but I said you should not be using thermal ultrasound, and you should be using only a very low intensity, non-thermal 20% type of ultrasound for fractures. So the trick there is that you might go for this B, but it is not B. So that means we have three other options, A, C, and D. You're talking about a fracture, but the question says to relieve pain. It doesn't say to heal a fracture. It says to help with pain. A, C, and D are all ESTIM, all ESTIM related. So I'm going to think about what stands out with A, C, or D that is to relieve pain and won't hurt my fracture. Okay, so you have A, monophasic post-electrical current, C, transcutaneous nerve stimulation, D, neuromuscular electrical stimulation. You're relieving pain. You should go to the one that helps with pain, which is C, which is TENS, basically. Okay, that's why knowing the type of ESTIM is important, because if you think TENS just means the little box, the TENS unit, that's not necessarily true. TENS stands for transcutaneous electrical nerve stimulation, and that is for pain, and the question is asking for pain. It will not hurt the fracture, it won't pull on the fracture, because if you think of what TENS is, especially high rate TENS, it's just a tingly feeling. If you don't use low rate, there's no muscle twitch, there's nothing, so it won't hurt a fracture. If you do move the muscle, that could hurt a fracture, so D is out. And A, it won't hurt the muscle, but it just won't really do anything, or do anything as much as C. Because we know that is, from the previous question, we know that is for acute inflammation, and it's not asking you to help inflammation, it's asking you to help pain. Okay, so the pain one is C. And last but not least, your patient is being seen in therapy 3 days post-surgical repair of the ulnar nerve. Based on the diagnosis, which of the following modalities is most likely to be in the plan of care? Okay. 3 days post-surgical repair of the ulnar nerve. Okay, so something acute-ish, right? Something that just happened 3 days ago. That might lead you to be like, cold pack. But remember, I said cold pack is great for acute and acute inflammation. However, when it comes to nerves, the cold is the one that has the most effect on nerves, right? And regenerating nerves at that. So if they went in the nerve and repaired it, that nerve is definitely regenerating and healing. So this is one of those questions that's trying to trick you to pick cold pack because you think acute, cold, but not always. And this is one of those cases, okay? The fact that the specific diagnosis, which the question does say, based on the diagnosis, that means it's telling you to pay attention, not that it's acute, but what is the diagnosis? Repair of the ulnar nerve. It's telling you, and I always tell you guys, the boards gives you information you need, and you should never add to the question because they're made to give you exactly what you need. You just have to pick out the right things. You have to notice the right things. It wants you to look at the diagnosis, which is the repair of the nerve, okay? And you should also see that it's acute. So it wants you to trick you to pick B. But the fact that it's a nerve repair specifically makes it not B, okay? So I would actually eliminate B because of that, right? A, definitely not. I would also eliminate because, again, hot is not done with acute. So A and B are out, okay? Then you have C and D, diathermy or post-ultrasound. Diathermy can be also non-thermal, but again, it's not as commonly used, period, and it's not as commonly used for this type of condition in such a small area. Diathermy, if you even remember in our lab at the looking at the machine, or if you have ever seen a machine, if you're from another lab, it's usually that big bulky thing, right? That's for you to put it on a little wrist is rare. If you're going to choose between ultrasound and diathermy, which have a lot of the same effects, but you're working in a small area, you're probably going to choose ultrasound. That is more indicative to a small area. Oh, I'm sorry, ulnar nerve is over here. It's not this nerve, it's this nerve, but still, it's still a pretty small area. So diathermy to me, just, it's not the worst, but they don't indicate what type of diathermy, first of all. They don't say thermal, non-thermal, and it's just usually for bigger parts. So I don't like it. So I'm gonna look at C, ultrasound. Does it say thermal? No, it says pulsed. That's good. Pulse is good for acute. So the answer is C. If you do look at the research and if you do look back at your textbook, you will see that non-thermal ultrasound is commonly used for like acute injuries and stuff, after surgeries, after carpal tunnel, after repair, stuff like that. So C does make sense. And that's it. There's no more questions. That is the last one. I hope the quick review helped you organize some things in your mind, and I hope the breakdown of questions helped you a little bit more with modalities. Again, I did focus on the bigger modalities or the more commonly used modalities rather than things like traction or aquatics or diathermy or whatever, even though it was thrown into some of the other questions, which is why you still kind of got to know them, right? But if modalities is not your strong area, I would focus on the ultrasound, ESTIM, and hot pack and cold pack, rather than like going too deep into a diathermy or a laser or something. You'll be okay if you get the other ones right and miss that one question about a laser, I think. But again, my little tidbits are just to guide you. In the end, you know your strengths and weaknesses, and you do have to kind of pick and choose where your focus is, right? So focusing on the big three, MS, neuro, and cardio, focusing on the bigger modalities are gonna help you a little bit more. But if you got all that down, then focus on the small stuff. That's okay too, because you already got that other stuff good. So then maybe go in and dig a little deeper. But if not, then I would focus on the big stuff, okay?